Thank you for your invitation, Chairman, ladies and gentlemen. I would really appreciate to be here with you to talk about a topic which is not new, and in fact it is recurring. Microphone. Maybe I should use this one. Can you hear me better now? Can a technician come here to help me?
It's over there. It's...
Can you hear me now? Better? Yes?
Yeah.
Okay. More than 20 years ago, there was a paper by De Meester about true early lung cancer. And at that time, most of those patients with true early lung cancer died of cancer, so it was not true early lung cancer. And this year, Dr. Serfolio published another paper on true pathologic T1 cancer, and many of them had not been staged as clinical T1. Almost 50% of those clinically stage 1 patients' tumors were not pathologic stage 1. So there are problems that have not been solved in the last 25 years. The italics on the topic are not mine. They are the organizers. And I have seen that in the syllabus that you have, the italics have been replaced by standard letters between inverted commas. I don't know which is worse. There are two words in Spanish to define italics, cursiva and bastardilla. And cursiva is very similar. It sounds like curse. We would say curse in Spanish if we pronounce in bad English. And if you look at the translation of bastardilla, you can realize that at least the italics should be taken with caution. Because truth is very slippery, and it has many facets that depend on who is looking at a certain event. So the true early stage will certainly depend on the specialist. For many oncologists, all tumors that have no metastasis may be early or limited. However, for a molecular biologist, maybe the true early is that cancer cell that cannot be defined as malignant under the microscope, but that has some molecular changes that for him tell that the cell is already malignant. Also, the true early stage will depend on the intensity of the investigations. Simple chest X-ray, from simple chest X-ray to PET scan, through invasive staging, etc. Also, it will depend on intrinsic tumor factors, as we will see later, environmental and patient-related factors that are also very important besides the tumor factors. This is the stage grouping proposed by the ISLC, the International Association for the Study of Lung Cancer. Here there were some changes. Only small T2 tumors remain in stage 1B. The larger ones were put together with the N1 tumors, and here T4 tumors without lymph node metastasis or with higher metastasis were downstage from 3B to 3A. However, if we understand by early a relatively small tumor that is associated to a relatively good prognosis, there only remains in the table this set of tumors: the occult, the stage 0, and the small tumors T1, T2 without nodal involvement. Any tumor that has gone beyond the lung or the bronchial tissues should not be considered early. So how small is small and how good is good? We'll have to see it later, combining all these factors that I have mentioned in the previous slides. The occult carcinoma is a rare instance. I remember in the 20 years of our multidisciplinary tumor committee, only one case has been presented as occult carcinoma. That is a tumor whose evidence is only by cells in the sputum or bronchial washings, but that cannot be seen by bronchoscopy or imaging techniques. And it was rather troublesome to identify the place where the cells can come from, and the old rule said that at least 2 consecutive bronchial washings should be done to make sure where the tumor was in order to do a lobectomy or a segmentectomy. However, when surgery was done, survival was very good, 100% in only 3 cases of occult non-small cell lung cancer from the National Cancer Center in Tokyo, of a total of nearly 3,000 lung resections for lung cancer. So it's a rare tumor. Occult carcinoma was progressively being replaced by another expression, radiologically occult carcinoma, because there are all these technological advances that have helped us identify very small tumors. If you read this month's issue of the Journal of Thoracic Oncology, you will see a report from Japan describing a bronchoscope that is 3.5 millimeters thick with 1.4 millimeters ultrasound probe that can go as far as the 6th generation bronchi and identify very tiny peripheral nodules. So this is an advance. We also have the autofluorescence or fluorescence technique with contrast medium or without, using different lights of different wavelengths to highlight the presence of abnormal mucosal tissue. And we also have other technology that are based on the description of the vasculature of the bronchial mucosa that help predict the malignancy of those lesions. These are 2 examples of autofluorescence bronchoscopy by 2 different methods. And here you have the white light, the normal light bronchoscopy, that when you change the wavelength of the light, some areas become reddish or brownish, and this is not normal mucosa. It does not mean that this is cancer. It may be dysplasia, metaplasia, but if you have to biopsy something, biopsy this because this is abnormal. Here you have another method with a different technology that highlight the abnormal mucosa in a sort of dark bluish color. And we have this optical coherence tomography, which is fascinating. It looks like an ecography, but it is done with infrared light. And you can also apply Doppler technique to see the blood flow, and it really reproduces the image as a histology. This is the same image in histology. You can see the epithelium here, the lamina propria, the perichondrium, and the cartilage, very similar as shown on the histological slide. This is another type of optical coherence tomography, and with these techniques you can even identify a microinvasive disease. If there is here, there is none. This is a normal bronchial mucosa with the cilia and the epithelium and the lamina propria. So with this autofluorescence, what we have gained compared with white line bronchoscopy is that sensitivity is much higher. However, we lose some specificity. This is normal. Not all stained mucosa is cancer. As I said before, it may be dysplasia or metaplasia, but in these abnormal areas, we can identify the initial molecular abnormalities that will make that cell a cancer cell in the future. These small lesions, especially if they are carcinoma in situ, when treated by a variety of local techniques like protoporphyrin derivative treatment, cryotherapy, electrocautery, or brachytherapy, they are usually associated with very good complete response, 100% if they are carcinoma in situ, 91%, etc. So there is a role for endoscopic treatment of these small lesions if they are indeed carcinoma in situ and are not microinvasive. This newer technology, that the optical coherence image, may help us identify microinvasion but not everybody has this high advanced technique. What about small tumors? Going now to macroscopy, which is our field. We thoracic surgeons deal with macroscopic lesions. What we have here is the International Staging Committee of the International Association for the Study of Lung Cancer determined that in pathologic T1 tumors without nodal invasion and no metastasis, completely resected and without induction therapy, the best cut point to separate tumors of different prognosis within T1 tumors, that is those of up to 3 centimeters, was 2 centimeters. That's why now we subclassify T1 tumors into T1A, 2 centimeters or less, and T1B from 2 to 3 centimeters, with statistically significant differences in these two groups. The same with in the clinical setting, clinical T1, clinical T1B, T1A, T1B. So my hypothesis is that early stage non-small cell lung cancer exclusively determined by size is clinical T1A and pathological T1A without lymph node invasion and without distant metastasis. But what is a cT1A? Well, first of all, the tumor must have been properly staged clinically. Second, we may pay attention to histological type and differentiation grade, but also nowadays that most patients have CT scan and most of them will have in the future PET scan. These are important sources of information to subclassify tumors that have the same size. Other tumors, other factors like tumor markers expression, oncogene circulating cells may help, but this technology is not universally available, and I will not discuss it today. What is proper staging? Well, that is staging that follows the clinical guidelines. And there was a group of people who invested a lot of time and effort in studying, reading, meeting, and writing all the literature available to develop two algorithms that help clinicians to clinically classify tumors. This is the second algorithm based on PET or PET-CT. There is a very similar one based on CT only, but for reasons of timing, we'll only show this, in that some patients who have tumors without evidence of nodal disease by imaging still require invasive staging, either by mediastinoscopy, which is the most standard invasive method, or if you have it, by endoscopy and fine needle aspiration, if you have this technology available. And if you perform mediastinoscopy, videothoracoscopy, or any sort of fine needle aspiration technique, you should have in mind that the recommendation for an acceptable exploration is biopsy of at least these 3 stations, and that it would be desirable to have also the higher paratracheal nodes, but these are more difficult, and at least these 3 stations should be biopsied, together with stations number 5 and 6 if the tumor is on the left lung. Histology matters, at least in tumors that are very small, up to 2 centimeters. Here you have adenocarcinoma compared with adenosquamous. These are more than 20% survival differences. These are very raw data from the ISLC that have not been validated, but I want to show it to you just to see the visual impact of the survival curves of different histologies in small tumors. Because when the tumors grow, the effect of histology disappears. It is more important the size than the histology in larger tumors. And I have to thank Dr. Paul van Schil for calling my attention to these 2 papers that try to extract more information from a very basic technique, CT scan. Here, the tumor disappearance rate. On the lung window, the parenchyma window, we see the tumor. In the mediastinal window, we don't see it. Well, the more it disappears, the less solid component the tumor has. That means the more the GGO component, the more the GGO component, the less invasiveness of the tumor, the less pleural invasion, the less lymphovascular invasion, the less nodal invasion. So we can use this objective measurement to separate tumors that have the same size but different CT appearance. The same if you use this technology, the CT histogram analysis that tries to make a curve having the Hansfield units of each pixel in the image, and you have low unit and only one peak, which would be the best prognosis because it is a very soft, so to speak, not very solid or dense tumor versus high numbers and one peak, very solid tumors, or a mixed component, mixed tumor, low component and high component here. So all this can help to separate tumors that have the same size, because it was already very well known that the higher the percentage of bronchoalveolar carcinoma in the tumor, the better the prognosis. Now we not only have a visual image of this GGO component, but we can also measure it in a very objective way. What about PET? There are many papers. I want to show you only one. This is a meta-analysis of 13 studies, and all of them, or almost 11 of them, except 2, show that high SUV max is associated with poor prognosis. How high is high? Well, it depends on each patient, and it depends on your PET scan, on your procedures. So each center has a different unit for high SUV, but there is consistent and repeated evidence that high SUV is associated with poor prognosis. What about pathologic T1A? Well, the same. A proper intraoperative evaluation, proper pathologic evaluation, and then other factors must be considered to properly say that this is an early tumor. Of course, the surgeon has to determine the highest T and to palpate and to inspect the intrathoracic cavity to find additional nodules or metastasis, but very important is the systematic nodal dissection, either in its higher standard or in its lobe-specific modality. This is the first definition and the first technical requirements that were agreed internationally in a multidisciplinary workshop that took place in London in 1996. And you can see here that complete dissection of all mediastinal tissue is desirable, but at least 3 mediastinal nodal stations should be excised. At that time, we did not consider the possibility that nodal involvement was dependent on the nodal location, on the lobar location of the tumor, and 2 papers came after this definition, one regarding exclusively small tumors, another regarding all sorts of tumors, and even single or multiple end-to disease. And you can see that the nodal spread pattern was consistent in these 3 subsets of tumors. So we developed the concept of lobe-specific systematic nodal invasion, considering the nodal stations that had to be evaluated intraoperatively depending on the lobar location of the primary tumor. So this lobe-specific systematic nodal dissection was incorporated into the definition of complete resection, which is internationally agreed and that requires prospective testing. There is nothing definitive. We'll see if it works. Also, there are many surgeons against systematic nodal dissection because of the complications, because it is not useful to increase survival. But here we have, with the maximum evidence that we can get today, a meta-analysis of 3 phase 3 trials that all were positive in favor of what the authors call complete mediastinal lymph node dissection, and the global hazard ratio also favors systematic nodal dissection. And we also have a randomized trial which has been completed, at least for this part of the study, the effect on morbid mortality of mediastinal lymph node dissection versus sampling, and we see that mortality, morbidity, and mean stay is exactly the same for the two techniques. So there is no problem in performing systematic nodal dissection. This type of systematic nodal dissection also agrees with the recommendation by the UICC of the minimal requirement for pathologic and zero. So here these three nodal stations are the ones recommended by the lobe-specific systematic nodal dissection, and one of those must be the subcarinal. Pathologic histology also has different prognosis, as you can see here. And if we talk about the pure bronchoalveolar carcinoma, the Japanese have a lot of experience. This small type, less than 2 centimeters, is very rare. It is less than 2% of the experience in this large series. And when completely resected, it is associated with no nodal disease and with 100% disease-related survival. So it is very important. Pathologic histological grade is also prognostic. Here there is a very recent experience from Japan, and worse survival in the univariate and multivariate analysis is associated to poorly differentiated tumors. Here you have the hazard ratio of several survival times overall, disease-specific and disease-free survival. Pathologic vessel invasion, 3 presentations in San Francisco this year that associate invasion of the lymphatic vessels or venous vessels with a higher degree of invasiveness and poor prognosis. Also, the pathologist has to do his work by analyzing well the T factor and the N factor, registering the number of lymph nodes studied, the number that are positive, and their location. And with all this information, we have to certify that the resection is complete. But before my final slide, I want to tell you something that I just reflected on when I saw this graph here. It would be ideal if we could identify cells in the bronchial mucosa that have these very early changes without the cells being carcinoma cells yet. And if we could intervene here some way to reverse this progression into carcinoma cells, this here would be the really early tumors that we should treat in order to prevent carcinomatous progression. So the true early stage non-small cell lung cancer, I would consider 2 different settings. In the endoscopy setting, carcinoma in situ, which appears as occult or as radiographically occult carcinoma. In the thoracic surgery setting, which is our setting, I would consider 2 tumors, those properly staged as clinical T1A tumors, and I would separate adenocarcinoma with 100% GGO appearance or almost 100%, and solid tumors with low SUV max, whatever low is in your own hospital. For the pathologically stage PT1A, again, properly staged intraoperatively and so on, adenocarcinoma in situ, pure BAC, which is a pathological diagnosis, not a clinical diagnosis, would be one, and then solid, well-differentiated tumors with no lymphovascular invasion. Finally, I want to just call your attention on the fact that I have discussed mainly the tumor factors that contribute to prognosis, but there are patient factors, environment factors that also affect prognosis. Imagine, for example, a surgeon that does a sublobar resection to remove a T1A tumor and transgresses the tumor with the staplers. That's an environmental factor that will have a very poor prognosis. Well, there are others, but this is more complex than it seems. Thank you very much for your attention.
Thank you very much, Ramon, for this nice overview, and it seems that true early lung cancers are not that easy to find. As all the presentations are centered around early lung cancer, I propose to have the